Hello, this PowerPoint is going to be covering a TIA and a CVA. TIAs are transient ischemic attacks, and a CVA is a cerebral vascular accident or a stroke. A TIA is temporary impairment of the cerebral circulation. This deprives the brain of glucose and oxygen. Symptoms can resolve within an hour to a day. 1/3 of all strokes are preceded by a TIA. They usually disappear within an hour. The patient recovers completely. If they don't recover, it will be considered a stroke instead of a TIA. These can serve as a warning sign and an opportunity. The warning is an impending stroke. The opportunity is to take steps to prevent. So how can we take steps to prevent? We're going to make sure they're controlling their blood pressure. They can lose weight, stop smoking, alcohol abuse, controlling their alcohol, controlling blood sugar. And we need to make sure that they're taking medications as prescribed. Some signs and symptoms would be weakness, numbness, or paralysis on the one side of the body, slurred or gargled speech, loss of vision in one or both eyes, or diplopia, which is double vision, dizziness or loss of balance, and temporary lightheadedness. They can have a sudden severe headache. Remember, these are all short-lived. There's not permanent damage in this. A CVA is a sudden, prolonged loss of brain function. This can result in that inadequate blood flow to the brain, can lead to an infarction of the brain tissue, which is death of the brain tissue. Permanent damage, if not reversed, within 3 to 7 minutes. And there is usually related neurological deficits. About 1/3 people die from a stroke. Most have that permanent disabilities. The two main types of stroke is ischemic, ISCHEMIC, and this is a form in which it obstructs the artery. So these are your clots that we're looking at. The second is your hemorrhagic. So this is a rupture of the blood vessels. The two common areas is the cerebellum, which remember it has to do with your balance and coordination, and the brain stem. And remember, the brain stem controls those vital organs. It controls the breathing, blood pressure, and the heart rate. Some modifiable risk factors. Remember, modifiable are things that we can change. Would be controlling the hypertension, stop smoking, controlling type 2 diabetes, controlling the AFib, decreasing risk for a TIA, controlling your hyperlipidemia, controlling obesity. You want to try to control those weight. We also want to look at thrombogenic substances, and this is your estrogen or oral contraceptives, which increases your risk of a stroke. Also want to look at valvular disease or replacements. Non-modifiable risk factors, so things we can't change, are age. 55 years and older are at higher risk. Also, our gender. Men are slightly more likely to have a stroke than women. Our race. African Americans are at higher risk. Genetics. The big thing with genetics is if a blood relative has had a stroke in the past, that puts you at higher risk as well. I'm sure you have all seen the FAST on TV. So F, face, A, arms, S, speech, and T is time. So impending signs that you're going to have a stroke would be numbness or weakness of one side of the body. If you're having mental confusion, having difficulty speaking or understanding speech, impaired walking or coordination, or severe headaches. These are all your normal warning signs for a man. Now, not saying that women cannot have them, but women are usually misdiagnosed because we have unique symptoms. These unique symptoms are going to be nausea, facial and limb pain, general weakness, chest pain, shortness of air, hiccups, and palpitations. So you can just see that there's a big difference in your normal signs and symptoms versus what some women come in complaining of. And with some of these, women don't even go to the hospital right away because some of these are normal symptoms that we would see in other diseases such as your nausea, general weakness, shortness of breath, hiccups. So with a stroke, we have to remember that the infarct is controlling the opposite side of the body. So if you have a left-sided infarct, your right side is going to be affected. And if you have a right side infarct, your left side of the brain is going to be affected. So your motor nerves cross over to the other side of the body at the level of the neck. When we talk about speech, speech is usually on the opposite side of your dominant hand. So yet again, I am right-handed, so my left side of the brain is usually what's holding my speech. So it's the opposite of your dominant hand. So if you're right-handed, it's going to be the left side. And if you're left-handed, it'll be the right side. So some manifestations that are going to follow a stroke, we're going to talk, it really depends on what side of the brain was affected. So if you have left side of the brain was affected, you could have aphasia, intellectual impairment, slow and cautious behavior, right side visual defects, because remember, it's the opposite side. Short retention of information. They need to be reminded to complete tasks, and they have difficulty learning new tasks. And they also have problems with abstract thinking. On the right side of the brain, there are perceptual defects, impulsive behavior, they have poor judgment, they have the left visual field defects, they misjudge distances, difficulty distinguishing upside down and right side up. They also have impaired short-term memory, and these usually neglect the left side of the whole body. So they neglect their entire left side of the body. So aphasia is the absence of language. So if a patient has expressive aphasia, the patient knows what they want to say but are unable to get the words out. So they have an inability to speak. Receptive aphasia is the inability to understand the written or spoken words. So they can speak to you, but they're not comprehending what you are saying. There are some diagnostic tests that can be done. You can do a CT scan, which determines if there is a hemorrhagic, and it will rule out other issues such as brain tumors. An EKG, you can monitor if they have AFib. A PT-INR, we want to see how thin the blood currently is. You can do a transcranial Doppler. This is it determines the size of the vessels and the direction of the blood flow. A SPECT IDs the blood flow as well. An EEG will show the area that is involved in the brain. A lumbar puncture, it's going to show if there's if it's going to be more of a hemorrhage because it'll show blood in the cerebral spinal fluid. And the cerebral angiography, it shows any displacement or blockage of your vessels. TPA is a thrombolytic therapy. This is a tissue plasminogen activator. This medication can dissolve a clot, potentially completely to reverse the stroke symptoms. However, it must be given 3 hours from the onset of symptoms, not when they come into the ER. We have to know, when did your symptoms start? So if they don't come to the hospital until 5 hours later, they've already out of that TPA window. However, if they come quickly, we have time to give them that TPA. With TPA, they are at risk for bleeding or hemorrhaging, so we have to monitor close signs and symptoms of hemorrhaging or bleeding. The normal dose of TPA is 0.9 milligrams per kilogram, with a max dose of 90 milligrams. 10% of it will be given in a bolus, and the remaining amount will be given over an hour. So that's that 90% will be over an hour through an IV pump. So think like a nurse. Your patient just had a stroke. Do you want the blood pressure to be high, low, or in normal range? And why do you think that? To most people's surprise, we actually like to keep the blood pressure on a little bit of the higher side because it gets more blood to the brain to help save more tissue. If no meds have been given, they try to keep it around 220 over 120. If they are on TPA, they usually try to keep the blood pressure around 185 over 110. Yet again, it has to do with getting more blood to those tissues. Some interventions, we already talked about that thrombolytic therapy. We're going to manage any airways if we have to, which would be managing a vent, control hypertension, fever, and glucose. Now remember, the hypertension is going to depend on what the doctor wants it at. And we're also going to look at seizure precautions, prevention and precautions. Here are some nursing interventions. And yet again, remember, controlling that blood hypertension, it's going to depend on what the doctor ordered. Some post interventions are going to be treating the cause of the stroke. We're going to provide physical, occupational, and speech therapy. And we're going to look at the medications. We want to provide medications that goes kind of along with the treating the cause. So antiplatelets, anticoagulants, antihyperlipidemics, and antidysrhythmics. We also want to make sure we're maintaining a patent airway. So what are some modifiable risk factors of a stroke? So remember, modifiable, can you change it or can you not change it? And modifiable are things that you can change. So the answer here is going to be 2 and 3. So we can control our type 2 diabetes and they can control weight. They cannot control their age or gender. So following a ischemic stroke, thrombolytic therapy must be given within how many hours? Remember, that was 3 hours. To protect the patient from aspiration, what intervention should be carried out first following a stroke? So we want to set the patient up right for meals. We have a swallowing evaluation done. Avoid the use of straws or we use thickener for liquids. So rule of thumb is we don't do anything until a swallowing evaluation is done. So that would put you at number 2, having a swallowing evaluation completed before they can take anything by mouth.